Ladies and gentlemen, dear colleagues, my name is Diaman Tachi. I'm University Professor at Institute and Comprehensive Center for Inflammation Medicine at University of Lübeck in Germany. And I'm very pleased to talk about atopic dermatitis with a focus on safety of topical treatment, topical corticosteroids, calcineurin inhibitors, and Crisa. Atopic dermatitis is heterogeneous disease. It occurs very early in infants, in small children, school-age children, in children and adolescents, and it's presented with a different clinical phenotype. Later on, it might stay as a minimal disease, but it may also persist as a chronic recurrent disease. Atopic dermatitis is a disease with a different clinical pictures, and the prevalence of atopic dermatitis has increased. It differs from country to country, from 5 to 20% in children, and also in adults and adolescents, we've seen an increase of the prevalence of atopic dermatitis. In North America and also in Europe, it's the prevalence between 10 and 20% of the population. These are the most recent data published 2021. If you look, what is atopic dermatitis? It's a chronic disease. It's itchy disease, inflammatory disease that occurs most frequently in children, but also in adolescents, in adults. It follows relapsing course with times where you have a very low activity of disease and also high activity of the disease. And of course, some of this patient may have also a higher risk for comorbidities like type 2 inflammation, like atopic asthma, or they may have allergic rhinitis, and also more frequently food allergies and intolerances, as well as allergies of type 1 and type 4 allergies. If you look, how can we make the diagnosis? And I think before we start about any adverse events that may occur under the treatment with topical treatment, it's very important to understand does the patient has atopic dermatitis or not. We need a criteria to find out and also to make the right diagnosis. And the diagnosis is purely clinical. It's made based on the historical features, morphology, and distribution of the skin lesion, which are associated with the different clinical signs, like, for example, the itch. Classically, it is a Hanifin-Rika criteria, which are very well known to the vast majority of dermatologists, but also the United Kingdom Working Party is also having a criteria which are a little bit more suitable for small children and used mainly in the children. But basically all of them, they are criteria which have to be followed, because before we talk about tolerability and safety of topical treatment, is important that we are dealing with a disease like atopic dermatitis. And once we are talking about the topical treatment, which is part of my talk, and the side effects and also tolerability of this topical treatment occurred under the anti-inflammatory treatment for atopic dermatitis, is important to know where are we treating. And this is very important because the penetration and also the probability of getting a side effect is much higher, depends the population. For example, children are responding faster to the topical corticosteroids, but at the same time, since face is more affected and the larger body surface area, this may be also accompanied with a higher risk of absorption and systemic effect. Areas like folds, face are also more thinny areas where the skin is not very thick, and the risk of having the skin atrophy is much more present in the infants, small children, and especially if the localization is more in the folds. In the adults, we see the palms can be very frequently involved, which is not as effective, let's say, affected by the side effects of a topical treatment, like, for example, treatment with topical corticosteroids, because the skin is more infiltrated, more indurated, and the probability of having the problems of side effects with topical corticosteroids are much lower. And finally, what I think is also very important, that we have to distinguish that even a normal looking skin in the patient with atopic dermatitis, so-called non-lesional skin, differs from the normal skin. We see that the epidermis, the skin barrier, is impaired in the patient with atopic dermatitis. We see that the patient who are having an acute disease, they have a totally different phenotype of the disease from the patient who have a more chronic disease, where we see more lichenification, but also the thickness of the skin differs. The impairment of the skin barrier is very important in the acute lesion, and the chronic lesion, we see that the probability of getting a side effect is lower with a topical corticosteroid because the skin is becoming and having more higher thickness of epidermis. Learning with this, it's very important. Why should we treat patients with atopic dermatitis? And the topical treatment is the most preferred because the vast majority of the patients who have an atopic dermatitis, they have a mild to moderate form, can be controlled easily with topical treatment like corticosteroids, for example. And it is extremely important that we keep in mind that we have to control not only the inflammation, which is beneath the skin, beneath the epidermis, but also not to impact the barrier. If the skin barrier is impacted, which is a case in patients with atopic dermatitis, this deficient barrier may lead to the high risk of developing of the side effect if something is applied topically. At the other side, if something is applied topically and the skin barrier is not working properly, the penetration of the drug can be even higher, and this may cause systemic effect. So if the skin barrier is impaired, this is also having impact on the treatment with the topicals that we are using. But finally, it's very important that we decrease the inflammation, that we improve the skin barrier, and this is a challenge that we are having in our daily practice. Usually in the past, we thought atopic dermatitis is a disease in infants and children, which comes and somehow at the school age is going down. But this is the impression of pediatrician. Pediatrician, even with topical treatment, they are slightly less aggressive because the disease is having this curse with early onset, with a remission. However, as dermatologists, we see this very early onset without remission. Therefore, our perception is usually we need to treat more adequately. Disease activity adapted treatment with a topical treatment, for example, with topical corticosteroids. And we might have an early childhood, adolescent, or even adult onset. And in the different ages, different treatment option may be also available and also indicated. And sometimes it depends in which patient are we using which treatment option. My focus today will be on the current treatment option in atopic dermatitis on the topical, and my talk, it is specified on the tolerability and safety of a topical corticosteroid, calcineurin inhibitors, and PD4 inhibitor, Crisa. So I will focus on the topicals only. Once we are talking about the topical, of course, we have corticosteroids. We may divide them in a low potency, medium potency, high potency, and the very high potency. And I think that the vast majority of you are using low potency and medium potency, sometimes also potent, but the ultra potent are rarely used in atopic dermatitis. As a calcineurin inhibitors, tacrolimus and pimecrolimus are available. Pimecrolimus for mild to moderate, and tacrolimus for a moderate to severe form of atopic dermatitis. And recently, we have also a phosphodiesterase 4 inhibitor, Crisa, approved. And you see a lot of things are happening in the systemic treatment with dupilumab, baricitinib, tralokinumab, and new JAK inhibitors. But this is not a part of my talk. As I mentioned, how do we treat in our daily practice? This is still a stepwise approach. And either it's a stepwise approach, we do see that from a mild to moderate, but even in a severe cases, topical treatment could be a treatment option. Topical corticosteroids of class 2, that means moderate potent or moderate or potent topical corticosteroid for a moderate form of atopic dermatitis, or treatment option in the vast majority of our patients. Once we are discussing what are the topical treatment recommendation, one of the treatment option, it is also a proactive mode of action, which is approved with the tacrolimus, and also by EADV, it is also recommended to be a treatment option. How to taper it, how to do it. This gradual dose tapering, it is something that is recommended with twice weekly application. And the aim is to have a long-term safety. The treatment option that we are doing nowadays, they are, of course, important to have a good treatment efficacy, but that what matters in long-term management, it is the safety. American Academy, a proactive treatment on the areas commonly flare, there are no recommendation. tapering, no recommendation. And there are other different societies, as you can see. The gradual tapering or discontinuation after reduction in inflammation symptom is something which is also recommended. So once we are doing the topical treatment, it is important not only to think how we are going to treat the course, the acute course of the disease, but how we are going to maintain the treatment in the long term. And if you ask me why is like that, because long term is mainly where we have a problem in the disease. I think if you look to the atopic dermatitis, of course, it's a long-term chronic disease. Genetic predisposition and skin barrier defects are that what is increasing also the tolerability and safety of topical treatment. We have this non-visible skin inflammation, which make us a problem. Should we continue to treat? Should we stop to treat? If we do a continuous treatment, the risk of the side effects, for example, with topical corticosteroid and having a skin atrophy, is higher. And at what time should we stop? And if there's irritation and can frequently also occur, the question is at what time can we stop the treatment and how to stop? And once we have a flare, it's very fine, but we have also negative treatment of effects of the treatment, like for example, topical corticosteroids. So we have to take in account it is very difficult to manage disease, and especially what matters, it is how can we treat the vast majority of the patient adequately with anti-inflammatory treatment. And the most inexpensive treatment option are topical corticosteroids. These are still the first line anti-inflammatory treatment, and it is mainly on the areas used where it's a need, for example, where the patient are having also the acute signs and symptoms of atopic dermatitis. I think what is very important that we have to address the sufficient dosage. So if you have somebody with a very severe redness, with very severe infiltration and induration, then a mild potency of steroids is not adequate. At the other side, if you are using, for example, topical steroids on the face, then less potent treatment option are more adequate, because this is always considering benefit and risk on the areas that we are using topical treatment for the patient with atopic dermatitis. What we are also learning, how can we avoid that what's called rebound phenomena? What is the rebound phenomena? You stop the treatment, the disease is flaring up. And to learn this negative effect of a topical corticosteroid, it is very important that to have a strategy to avoid the withdrawal rebound. One of them is this proactive mode of treatment. After the initial response, the patient are treated twice weekly on a certain days, for example, Monday and Thursday, only once daily. And this is sufficient to inhibit the reoccurrence of the disease or to have a worsening of the disease. The other way around is you taper it down from the potent to the mid-potent to the less potent, and also decrease the frequency. So there are different strategies, but these are mainly done for one purpose, to avoid the rebound phenomena. Sometimes it is also very important to have a constructive use of steroid, because sparing steroids and avoiding side effect, this is the main issue in the strategy of the topical corticosteroids. So the benefits are known to you. Steroids act very fast and they are very effective in the short-term treatment. As a dermatologist, if you use them properly, they are also a safe treatment option. However, in a long-term management, if the patient are using topical corticosteroid not appropriately or in a prolonged management, and also having a high risk of the side effect, like for example, skin atrophy, that may occur, especially if the folds are treated with a more potent steroids. So as potent the steroids are, as difficult the areas to treat are, for example, face, folds, then the probability of getting side effects is even higher. We might see also the pigmentation abnormalities. Steroids may lead to the hyper or hypopigmentation, may lead to acneiform, rosacea-like eruption, especially around the mouth, but sometimes they may have also systemic effect. Even topical treatment may lead to the HPA axis suppression with the systemic effects. Patients who are on the topical treatment may have a systemic effect on the growth retardation. Even topical corticosteroids may lead to the growth retardation. We see that the patient who have atopic dermatitis have been treated for a long period of time with topical treatment only, this patient may even have a growth retardation. The Cushing syndrome today is very rare, especially rare because we are not using systemic treatment frequently. And topical steroids, it mainly depends from the area that we treat. For example, if it's less than 20 to 30% for a short course, the probability of having systemic absorption is lower. And another side effect, or something which is more typical, it is tachyphylaxis, that the treatment is not as effective at the beginning. And this is leading to more and more pronounced treatment and prolonged treatment with topical corticosteroid, which at the other side may have as a risk on a more skin atrophy and also typical corticosteroid side effect which may occur. Ocular toxicity may occur even with the topical corticosteroids, only in the cases of the prolonged treatment with a topical corticosteroid, and especially if the patient used widespread in the larger body surface area. Topical corticosteroids are not for the usage on the larger skin. Let me summarize, ladies and gentlemen, the long-term corticosteroid treatment disadvantages. One of them, it is if you have a skin atrophy and the areas of the skin atrophy, you use the topical corticosteroid of the potency, for example, on the face, then the skin atrophy may occur. And the skin atrophy is leading also to the smaller telangiectasia in this child. And you see it's a patient with atopic dermatitis, having dryness, cheilitis, sicca. But that what stays, and that what is also remarkable in this patient, it is that on the face, we have to avoid this, not using potent steroids and not using for a prolonged period of time. Otherwise, this may occur in the pre-existing atrophy, especially lesion around the face and around the eyes. These are also the areas where we can use short and also less potent steroid. Sometimes the steroid may lead also on around the eyes, but also around the mouth to the more acne-like eruption. This can happen also with a treatment of other areas where we see systemic effect, like an asthma, acne. And rebound phenomena we have talked, and it's very rarely that you see patient adults where you don't see that the dermis is gone. The collagen is that the problem in patients who are treated with topical corticosteroid. And this is skin, which is also shown in the patient who are having already a skin atrophy. So this is a contraindication to use steroids, topical steroids in this patient. So the typical side effects of the corticosteroids are not on a short term. They are mainly after long-term management and can be present in the skin in form of the skin atrophy, can be present in telangiectasia, acne-like, and also sometimes in a very severe skin atrophy, like in this patient. And who are at the higher risk? At the higher risk are the infants and children and less adults. Adults, if it's used more on the face, around the eyes, and also an area where have a need for a continuous treatment with topical steroids. So I think age and also the distribution are very important once we are considering the treatment for our patients. So the combination treatment can be also an advantage, especially understanding better what is important. For example, in this patient, as you see, the area, it doesn't look like it is in a skin atrophy. But if you come closer, then you will see, oh, the skin, what is happening? It is very thin. And if you enlarge this with dermatoscope, then you will see the vessels. And the vessels which appear here, the transparency which is increased, it is because the collagen synthesis is gone. And if you improve this, if the skin is improving, this is the skin of the patient on the folds normally, and this is the normal looking skin where you will not be able to see the vessels. So this is the area where you start the skin atrophy, and this is a very pronounced skin atrophy. So you can even control this with dermatoscopy. Contraindication, usage of steroids in the already pre-existing one. As I mentioned in this child, as you can see, patient with atopic dermatitis, typical Denny Morgany, and also in this child, at the beginning, you don't have a feeling. It's some scaling there, but that what matters is usage of even moderate potent steroid for a prolonged time on the face of the young children, where you see the telangiectasia, the skin is thin, and is leading not only to the skin atrophy, but also, as you can see in this patient, in telangiectasia as a part of the adverse event of the side effect was the topical corticosteroids. And I mentioned this acne-like, and the patient didn't have nothing on their skin, but it is a sign of the systemic side effects of the topical corticosteroid. Also, patient with Denny-Morgany, typical atopic patient. And once they have something on the face, they are starting to use topical corticosteroid. And this is aggravating this. And the patient cannot go out of the treatment. And this is an additional side effect of the topical corticosteroids. They may lead toward rosacea-like disease, or even in a young patient in an acneiform lesion on the face. The second part of my talk will be also focused on that. If you treat the patient with atopic dermatitis has impaired the skin barrier, but also they may have also skin microbiome dysbiosis. So we may have a presence of more bacteria, and especially Staphylococcus aureus. This dysbiosis is increased with a Staphylococcus colonization, so it may lead also to the more higher risk of the secondary bacterial infection, and this may increase also atopic dermatitis severity. The question is, if you have a patient like this, and then you are treating the patient, and for example, with topical corticosteroid, and if you look in the SMPC, you will find out don't use steroids, for example, in a clinically infected skin. But if you use it, you will see in the vast majority of the patient an improvement, because if you can see in a baseline, in a flare, and a post-flare, that also the continuation, the treatment of the patient is improving, but is not also increasing the risk of the skin infection. And the question is why? If you look to the controls, you look to the baseline of the patient who are having atopic dermatitis, if they have flare. If the patient are having flare, the vast majority of the dysbiosis is because the staphylococci are all over the skin. If you treat them intermittently with the topical corticosteroid, the skin is improving, but also the skin microbiome is improving. So it's not the topical corticosteroids which are improving the skin diversity, the microbiome diversity, but it is mainly the anti-inflammatory effect of the topical corticosteroids. And I think this is also important. These are patients with control, baseline, and these are non-staphylococci, and this is Staphylococcus aureus post-flare. We see nice improvement and nice restoration of the skin microbiome. So it means anti-inflammatory treatment may have also an antibacterial, antiseptic effect, because the effects are systemic. And what are the benefits of the topical corticosteroids? I know you are aware of that. We usually use the weak one for the face, like for example, hydrocortisone acetate. Moderate potent, we also prefer predicarbate in Germany. The potent one, mainly, we suggest mometasone or methylprednisolone. Aceponate, fluticasone is also a treatment option, but we avoid class 4 steroids. These are no-go. And in the severe cases, the weak class 1 is also no-go because the benefit risk is low. So mainly the class 2 and class 3 from moderate to potent 1. And you know the limitation, it is mainly because of the long-term management. Long-term, what is long-term? More than 4 months, and can cause skin atrophy, especially if you see after long-term use. This is a normal looking skin and a normal skin, and this is skin atrophy induced by topical corticosteroids. But remember, it's not only the epidermis. The dermis is also involved because the collagen is gone. And what do the patient do? And a side effect of a topical corticosteroid, it is also steroid phobia. So if the patient and their parents have a steroid phobia, they will avoid the usage of the steroids. So what do? They will go to Dr. Google and they will buy a cream, for example, the Wow cream. In hospital, it was investigated what is the content of this herbal cream. And the content of this herbal cream was a very potent steroid, very potent and mild, very potent betamethasone. So all these different herbal creams offered as a non-steroidic are containing huge amount of the steroid. So please also education, it's very important. Steroid phobia, it is let's say effect of the topical corticosteroids, fear from the steroids is a part of that of adverse event that we are learning this. And what about the other effects? Can, for example, the use of the topical treatment lead to, let's say, comorbidities like a type 2 diabetes? Interesting. Just recently, it was shown in the registry from Denmark. So if you look patients with have no topical corticosteroid exposure, how many event, and what is the incidence rate per 1,000 patient year in adults, and any topical steroids is almost doubling of the risk to develop type 2 diabetes. And if you see very potent corticosteroids, these are the most higher risk associated with the occurrence of the type 2 diabetes. It means also topical corticosteroids may have a local reaction, like skin atrophy, telangiectasia, and that may lead also to the acne-like diseases in the face, rosacea-like, may have a systemic implication. But one of the systemic implications after the chronic or long-term use of a topical corticosteroid may be also the occurrence of type 2 diabetes. And there are a lot of questions about the side effects which may occur in a long-term run, in the long-term management of topical corticosteroids. And if you have a disease which is chronic like atopic dermatitis, we are seeking for the option for a corticosteroid-free option. And pimecrolimus, crisaborole, and tacrolimus, these are at the moment available treatment option for the treatment of a mild to moderate, pimecrolimus and crisaborole, and tacrolimus for moderate to severe atopic dermatitis. Since my topic, it is on the side effect of the topical treatment. These are the patients who are treated intermittently with topical steroids. You see that the microbiome or let's say a risk of infection is still there. But once the patient has been stabilized and then continued in a long-term management with calcineurin inhibitors, like in this case with the tacrolimus, then we see that the skin is also improving. So it's not treating the patient, it's also a risk and not only the benefit. What are the most common adverse events observed with the topical calcineurin inhibitors? It is burning, pruritus, and pain. Pain is not as common. We see that burning is equally occurring with tacrolimus and pimecrolimus, slightly higher with tacrolimus, but not significantly higher. Redness is not very frequent, it's only 0.9 to 2% of the patient, but that what comes, it's a burning, and especially burning on the face in the young adults. What do we see? That the majority are mild to moderate at the beginning of the treatment, and later on it decreases. How can you bridge this? For example, with a concomitant use the first 3 days with topical corticosteroid, which I do not prefer, or sometimes putting the ointment or the cream in the refrigerator, cooling this, using on the face or on the areas is leading to the less burning sensitization. But it's important, burning is only the first days, and later on the intensity is decreasing. And new treatment option, it is crisaborole, which is having similar effect like topical calcineurin inhibitor. The newest data are showing that they are on the effect of the pimecrolimus, improving the patient with a mild to moderate atopic dermatitis. Treatment response is good, is not excellent as we would like to have the new treatment option, but it's the corticosteroid-free treatment option of our patient. And that what comes as adverse event, it's reported skin pain compared to the vehicle, 4 times more frequently than a vehicle. The most recently presented network meta-analyses have shown that crisaborole, if you look what are the safety of the crisaborole, it means 10% of the patient have reaction on the application side, and about 6% of the patient are reporting pain-like impression on the area where you have the application. And skin infection is very rare. Erythema is also rare. So from a tolerability, crisaborole is well tolerated. So you can compare it also with the risk of skin infection redness with a vehicle, because the study was done also double-blind vehicle controlled. And you see also in another study published by Emipala, crisaborole 2% compared to vehicle. So your application side It is usually pain in a 2%, 3% of the patient. So it's not really very high. So showing that the tolerability is even good. It's even excellent, as good as with topical calcineurin inhibitors, even if not better. So from the safety profile, treatment with a phosphodiesterase 4 inhibitor, topical, Crisa is a safe treatment option for our patient, with only few patients who may have a reaction on the application side. The major one, it is more the feeling of the pain on the area which is used. If you look to the calcineurin inhibitors, I think in a long-term run, especially on the long-term management of tacrolimus and also pimecrolimus, especially in the children, if you compare it with a low or mid-potency of topical corticosteroids, we don't see a risk on bacterial infection, on a viral infection. The skin atrophy, it may occur to 8 to 10% of the patient with steroids, but this is not the case with the calcineurin inhibitors. If you see systemic adverse event, this is also not observed in the children. Viral infection also not higher than in steroids, and also other side effects. So topical calcineurin inhibitors in children, but also in adolescents, in adults, are having an advantage. However, since the black box warning occurred 15, 16 years ago, the use of the calcineurin inhibitors is much, much lower, and mainly because the safety data of the potential risk of malignancy. There was a US FDA black box warning on topical calcineurin inhibitors, and there are many post-marketing survival and clinical experience, but this didn't help. Let's say 10 years ago, we have also published malignancy concern of the topical calcineurin inhibitors for atopic dermatitis, and we listed facts and controversies. 10 years ago, we mentioned that according to the latest knowledge, there is no scientific evidence of increased risk of malignancy due to topical treatment with calcineurin inhibitors, but it takes time until the first studies are published. What is the risk? If you compare the risk and we look carefully to the risk, is this existing or not? If you look for the oral tacrolimus, for example, then the risk is there. Of course, we are expecting. But what about the topical? The minimal systemic exposure. It is not sufficient to lead to a high risk of any safety signal. If we see 92% of the blood sample, they have a low concentration, 70 in a lower limit of quantification. So if the skin is good, it's improved, systemic absorption is even lower. This knowledge led also to a new study, which was confirmed and also conducted all over the world, mainly North America and also in Europe. And the aim was to look prospectively as an observational study, comparing tacrolimus ointment 0.03, 0.1, and looking as a main endpoint cancer event, except the non-melanoma skin cancer. And it takes time until the study gets completed. 8,000 patients have been enrolled, and a lot of these patients have been censored and looked. And finally, after 10 years, almost 1,000 patients stayed on this one, and all these patients have been followed for years. So we are talking about 44,000 patient years where the patient have been observed. And this is very important to have the evidence. And the evidence is showing that more than 2,000 pediatric patients completed the trial. What are the main outcomes on the topical calcineurin inhibitors and safety profile? Observed person year, 44,000 more. Expected cases of the cancer, 5.95. Observed, 6. Risk not existing. So this study, for the first time, have shown, it's called Apple study, that the risk for cancer in patients who are treated with calcineurin inhibitors in case of tacrolimus is not there. So this is good news for us, good news for our patient. And finally, since almost 6 months, we have this information that in the long-term management with calcineurin inhibitor, the black box warning is existing still there, but what is important, it is not practically there. So what is happening in the very near future? We are hoping that with Crisa, the first drug is coming on the market in some of the countries, and other treatment options are already knocking on the door with the ruxolitinib and also tapinarof, 2 drugs which are also enlarging our armamentarium on treating our patient with atopic dermatitis, but they will bring also new safety profile. So it will be very interesting to learn more about the safety profile of the future. So summarizing, atopic dermatitis is a challenging disease. The vast majority of the patient, 80% of them, can be managed with topical treatment. Effective treatment option like corticosteroids, calcineurin inhibitors, and also recently PD4 inhibitors on the market. And the safety profile of these compounds is established for many years. Even the calcineurin inhibitors, which had a black box warning regarding the long-term safety and potential risk for development of malignancies, are more relative. We have new data showing the minimal systemic exposure. And if topical treatment is used properly, adequately, in as needed base in the areas from a dermatologist or from the physician with a knowledge, with deep knowledge, how to use topical treatment, these are not only effective, but also safe treatment option for our patient. With this, I would like to thank you very much for your attention.